This program is brought to you by Emory University.
Good morning, everyone, and welcome to another edition of Friday Fellows Conference. Our speaker this morning is Jeong Kim. Hwan is a fourth-year fellow in our research track. He's originally from Korea, born there, moved to the United States as a teenager. Swarthmore College as an undergraduate, and University of Chicago for medical school. Came here to Emory for residency, joined our clinical investigator research track, worked with Drs. Kayumi and Vaccarino, if I'm not mistaken, during his research years, and again is now a fourth-year fellow and is currently applying for heart failure and transplant fellowship. He's a little under the weather, so I thank him for gutting it out. But COVID negative this morning, so I thank him for sticking it out and giving his talk this morning. Hwan.
Thank you, Dr. Williams. Hi, everyone. My name is Jeong Kim. Today, I'm going to talk about inflammation and as a new emerging therapeutic target in coronary artery disease or any atherosclerotic disease. I don't have any disclosures. So we'll start with the case. So it's Miss T. She's a 64-year female with a history of CAD, hypertension, hyperlipidemia, pre-diabetes, and a former smoker who's visiting cardiology clinic for annual checkup. She's feeling well overall. She reports she's doing exercise routinely with walking 20 minutes for 5 times a week. She denies any angina, chest pain, or dyspnea exertion during the exercise. And she's taking all of her medication without any difficulty. There's no reporting side effects. A bit more history of cardiac history. So she has a known total occlusion of the non-dominant RCA with the collaterals that was seen in the 98 with angiogram. She had a more recent cath done in 2015 for chest pain evaluation at the time. Really showed 80% mid-circ with hemodynamic significance with FFR, and they're getting another stent at the time. Otherwise, no CTO of RCA and really no non-obstructive disease in LAD. And more recently, with an echo done in 2018, showed normal EF, mild LVH, grade 2 diastolic dysfunction, mild valvular disease, but nothing really significant. Her current medications are really appropriate therapies, I would say. Aspirin, high-intensity statin with the atorvastatin 80, carvedilol, Imdor, and lisinopril, and she's tolerating them all without any recent change in doses. On exam, vital signs are good. The exam is remarkable. Lab recently was remarkable. Lipid panel is here shown, really shows well-controlled on maximally tolerated statin therapy right now. So we congratulate her on keeping up with the routine exercise and keeping up with the good control of blood pressure and cholesterol. We also discussed the importance of continuing heart-healthy diet for her health. And we're about to conclude the visit, and she asked us, is there anything that else we can do additionally to further risk having a heart attack in the future? So I'm going to try to kind of think through this case a little bit more. So from a physician standpoint, she's a 64-year female with known angiographic proven CAD with a prior PCI and traditional risk factors such as hypertension, hyperlipidemia, former smoker. She's really well controlled with the blood pressure and LDL on a really appropriate medical regimen. But the question is there really anything else that we can further optimize to reduce her future risk of AST events? And is there any test that is available to discern the risk a bit better at the moment? I'm going to try to answer these questions for the next 45 minutes or so, focusing on the concept of inflammation and it being a therapeutic target there. We're often undertreat or not treat at all based on what we have been doing for the past 20, 30 years in preventive cardiology. So this is the topic of my focus of my talk for the next 40 minutes. Objectives of the talk will be to review the role of inflammation in the pathogenesis of atherosclerosis, and also understand the concept of residual inflammatory risk in the atherosclerotic disease, And also, we want to become more familiar with the current literature that has examined the therapies targeting the inflammation specifically in treating cardiovascular disease. So what is the role of the inflammation in atherosclerosis? So to do that, I want to go back and a little bit go in detail about the actual pathogenic mechanisms of CAD. This is a pictogram of the atherosclerosis we all in medical school. Basically, everything starts with the noxic injury stimuli that's activating the endothelial wall of the intima. And with that, this endothelial lining becomes permeable and it's less LDL, and also lets the some of the leukocytes, including monocytes, into the intimal wall. LDL gets oxidized and it becomes, which is not oxidized LDL is one of the culprits to the formation of the plaque. At the same time, the monocyte becomes macrophage, and the macrophage ends up engulfing the oxidized LDL, the scavenger receptors, and that fat-laden macrophages become foam cell, which we all know as the unit that actually aggregates to form fatty streaks and goes on to cause plaque formation. This is a more comprehensive pictogram of what's going on. So, but the foam cells are there to initially sequester all the toxic oxidized LDL, but then it becomes dysfunctional in that it's not able to clear the lipoprotein LDL effectively. So this imbalance between the uptake of the LDL and then the clearing of the LDL eventually leads to the demise of the foam cells and leading to the cell debris, release of cytokines that are pro-inflammatory, and it becomes this big basically mess. And at the same time, the cytokines and growth factors started recruiting the smooth muscle cell from the media into the intima, causing the formation of the fibrous cap, and eventually that fibrous cap and this lipid core, necrotic core, becomes the plaque, and it goes and grows over in the future. And when it bursts, it leads into a clinical myocardial infarction. As you can see, that the process of the atherosclerosis it does revolve around the LDL. The LDL is initially permeating into the intimal wall, and that becomes a part of the actual core of the plaque. But then you can appreciate the actual process of the pathogenesis actually does involve quite a bit of the I would say immune system and inflammation activation of those components to actually lead to the pathologic nature of the plaque formation. So why does inflammation matter? As you see, this is a big part of it, but why does it matter clinically? So to discuss that, I wanted to kind of go over and step back and then discuss what's been going on in preventive cardiology for the last 50 years. This is a diagram looking at the mortality of the cardiovascular disease for the past 60, 70 years. And you can appreciate there's a clear continued decline of the cardiovascular mortality, coronary heart disease mortality, stroke mortality, as you can see here. Why is that? Because we've done very well improving our knowledge and coming up with the tools that we can use to treat our patients. Starting the 60s, there was framing a HERT study looking at and identifying the traditional risk factors that we now know of: smoking, hypertension, hyperlipidemia as a major risk factors. And we started noticing the components of the LDL metabolism, looking at the LDL receptors. And then we have also now learned in the 80s that the lowering the cholesterol does help reduce the burden of the cardiac disease. And we all came up with the statins to actually treat the lipid, and also came with ACE inhibitors and calcium channel blockers. And finally, in the 90s, we came up with the hard evidence to show that statins do improve the not only LDL, but actually the major clinical events of the cardiac disease. And it becomes really the hallmark of our weapons to treat atherosclerotic disease in our population. But there's still also some signal that as you look at the trend of the decline, that maybe the slope of the decline toward the last 5 to 10 years is not as precipitous as we saw back in the 70s or 80s per se. So this is another pictorial representation of what we have kind of come up with for the past 34 years, 30 years or so. This is basically the summarizing the relationship between the levels of the LDL and then their associated risk of cardiac events in various statin trials. There's P's represent placebos and T's represent treatment arms. So basically, this is the FOURIER trial. Again, the reduction in the LDL level and the reduction in the event rate, is quite considerable for any kind of combo of this PNS based on which trial you look at. Overall, when you plot this, the relationship becomes really clear that basically the lower the better. The lower the LDL, the better off the patient is, and this has become really the core principle of taking care of patients with CAD in the past 30 years in preventive cardiology and preventive medicine. But is it really? I think that we're now reaching the point where we have our second thoughts, and what are we missing here? And then that's the point that I want to kind of make during our talk today. This is we are now in the era of PCSK9 inhibitors for the past 10 years, and this is one of those PCSK9 inhibitors, the outcomes trial, FOURIER trial in 2017. It was a multinational, multicenter RCT. With the patient with a known CAD and the LDL above 70, despite being on an aggressive statin therapy, maximally tolerated, and was randomizing 24,000 people into the evolocumab versus a placebo. What's remarkable, as you all know, is that the reduction in the LDL is quite remarkable at the onset of the therapy. That we see the placebo is staying around 90s, which is not too bad, 80s to 90s, which is not too bad, but still modestly controlled. But then once you start evolocumab, there's a huge drop in the LDL down to the 30s, which is not the number that you typically see in the previous traditional statin trials. And you say this would be really, really well controlled, clinically speaking. However, if you look at the actual outcomes of these two arms, the reduction sure is significant statistically. There's about 2.2% of absolute risk reduction in this outcome trial endpoint. However, the degree of the reduction in the outcome rate, event rate, is actually smaller than you'd expect based on the actual pure LDL reduction level. So if you are really thinking, we are thinking about just purely LDL atherosclerotic disease purely due to the LDL and being as an LDL disease, then this really doesn't seem to be quite fitting the understanding of our disease process. And another thing that I want to kind of point out is that if you just focus on the red line, which is the treatment arm of this trial, these are basically now the group of patients who are being treated with the maximally tolerated statin and then now PCSK9 inhibitors. You can see up to 12.6% of the population still suffering from some adverse events within the 3 years of follow-up in a trial population. So they do still suffer from residual risk of cardiovascular disease despite being aggressively on aggressive therapy for their lipid-lowering medications. So maybe it's the inflammation, as I mentioned earlier, so that we're missing, that CAD's atherosclerotic disease component consists of not only the LDL, but there's a whole slew of the inflammatory process that goes on to cause this disease. So maybe it's LDL. So CRP is a well-established marker for inflammation, as we have seen for the past few decades. And then this is basically the same trial, the FOURIER trial, but now treatment, and not the treatment, but placebo arm. And they're looking at the event rates of the various outcomes, the composite events, CV death, MI, stroke, and then revascularization, things like that, across the spectrums of the CRP level. And you can see the higher the level of the CRP, there's higher incidence of the adverse events, meaning that the levels of inflammation are significantly associated with the rate of the cardiac events. Not only that, if you actually compare looking into the treatment arms of the same population, there are two things to take away from this graph. This is the primary endpoint, this is secondary endpoint, basically the same thing, same message. The reduction in the event rate from treatment of evolocumab, which is red bar from the blue bar, when you plot them across the different groups of the CRP level groups, the actual absolute risk reduction is the greatest in those people with the highest CRP level, meaning the highest levels of inflammation, thus highest risk. The treatment effect of the PCSK9 seems to be the greatest. The more important thing I think that I took away from this graph is that if you again focusing on these red bars, that the group that's already treated with the statin and the evolocumab, across the span of the high sensitivity CRP, the risk of ASCVD events is basically still quite significant, meaning that people who have levels above 3 of high sensitivity CRP, despite them being treated with statin and evolocumab in this trial, they suffer from 15.5% of the events during this 2-year follow-up. And this is the concept of residual inflammatory risk. This group, for example, who has presumably very low LDL down to 30s and 40s with the PCSK9 inhibitors and the LDL, yet they have elevated the CRP, thus they do have this residual inflammatory risk of their atherosclerotic disease, and this is being basically seems to be undertreated in the current era of our preventive cardiology. So again, this going back to our pictorial diagram of the process of atherosclerosis, LDL is the initial insult, and then that's the component of the actual necrotic core and the foam cells, and then leading to plaque formation. But such as the steps like this, such as this, kind of connecting and activating and then recruiting the immune cells and activation of inflammatory system and pathways are really the another component of the atherosclerosis that could be potentially treated as a target as we talk about residual risk or the elevated risk despite our efforts to reduce the LDL. This is basically a meta-analysis of the epidemiological course looking at the different types of the cytokines involved in the inflammation, such as IL-6, IL-18, MMP9, things like that, and to see if they're really truly translated into the clinical outcomes. Yes, and there was, and everything showed that increase in the plasma levels of the cytokine levels were associated significantly with a higher incidence of adverse events in this meta-analysis. The problem is, though, the cytokines are difficult to study. There's multiples of their pathways they're leading and they're interacting with the components of the atherosclerotic processes as well as inflammation. So it's really hard to pin down on one linear pathway. However, this pathway that I'm going to focus on for the rest of the talk is something that's been extensively studied for the, I would say, past 30 years. And then, has been really successful in identifying some of the potential treatment options. So we'll focus on that a little bit more for our talk. Basically, this is a pathway in response to different types of the injury or toxic stimuli, such as cholesterol crystals, neutrophil traps, and the flow change or the hypoxia. And the NLRP3 inflammasome is assembled and senses these anoxic stimuli and activates the IL-1 beta into active ones and down cause the further downstream effect of signaling down to IL-6. And both IL-1 and IL-6 are thought to be playing the direct causal role in the actual vascular inflammation and the atherosclerosis. And further down, the IL-6 leads into liver, causes liver to release the CRP, which is we were basically measuring, and that's the overall gauging the degree of the activation of this IL-6 signaling pathway as a basically barometer or thermometer of this inflammation in this setting. So to notice that the CRP may not be playing the causal role. It's rather the upstream of the this pathway, but the CRP has been traditionally and historically have been used as kind of a measurable assay for this pathway to measure the overall inflammation. So IL-6 is central to this kind of signaling pathway, and then studies have again shown that IL-6 level in the plasma is associated with the increase in risk of ASCVD. So for each standard deviation increase in the log scale of the IL-6 plasma level, there was about 25% increase in the MI or cardiovascular death in the meta-analysis. More evidence to support this idea that this pathway is playing causal role. This is a manually randomized study looking at the polymorphisms in the IL-6 signaling pathway. Those polymorphisms were shown to be associated with the lifetime reduction of the lower levels of CRP, which is the empty squares. As you have more copies of the SNPs, you have a lower risk, lower level of the CRP, and also that lower risk of coronary heart disease. So really showing again that the causal role of the IL-6 pathway in this relationship. Yet the IL-6 is not the common assay that's clinically available. We often think of CRP being more readily and already clinically implemented. So the CRP may be a better marker to study. As you can see, this is quite an old study already. It's dating back to the 90s, looking at the CRP level and then CV outcomes. And this was based on the Physicians' Health study, looking at 540 apparently healthy men, and they were not only got the baseline CRP measured, but also a study was looking at the effect of aspirin versus placebo. On the right-hand side, so basically there's quartiles of the CRP level and looking at the various clinical events. And you can see this, the higher the CRP level is translating into higher incidence of the myocardial infarction, for example, which is significant, and also ischemic stroke, the same story. But another important lesson from this study was that, if you plot the association between the increased levels of CRP and then increased levels of the risk of having an adverse CV event, that the relationship seems to stay relatively stable over time, whether you follow for 2 years, 4 years, or 6 years or beyond. That the association seems to be quite stable, meaning that unless we check CRP in acute infection, acute illness, when you measure in a more stable setting, it is really a reliable assay and marker for inflammation, and then translates to cardiovascular outcomes over time that can be followed. Third part of the study was, as I said, looking at the effects of aspirin. As we know, aspirin is not only antiplatelet, but also anti-inflammatory medication. Depending on the CRP level at baseline, the effect of the aspirin and therapeutic benefits seem to be the greatest when you look at the higher levels of baseline CRP. As you can see. After this, there's a whole slew of group of epidemiological cohorts and studies, clinical cohorts have studied the CRP and then their relationship with CV outcomes. And this is sort of a more recent meta-analysis looking at that. And then you can see that the increase in the CRP level is associated significantly with the mortality in all these cohorts. So it's really has been established that CRP, this is again the pathway that I showed earlier, is a good kind of indicator of the quantify the degree of the inflammation that's underlying one's CAD or atherosclerotic disease. And in fact, if you look at the cholesterol guidelines that are current, this is the recent the current cholesterol guidelines. It's actually hidden here one of the risk marker for an individual, meaning that if you were to have this information, for example, such as Lp(a), Lp(b), things like that, high sensitivity CRP of 2 is considered as a marker that indicates that individual has a higher risk than the person who would otherwise would have a lower CRP level. So it does really, it has played into some part into the guidelines in the clinical setting, but yet I think there's still more that could be done. So going back to the concept that I mentioned earlier, the residual inflammatory risk, we talked about this evolocumab treatment arm in the red bars, that despite being treated with a statin, evolocumab, having a higher CRP level does put you at a high risk of ASCVD events. And this is another similar depiction from the SPIRE trial, which is another PCSK9 inhibitor trial. Basically modern clinical trial data looking at the relationship, the CRP and the event rate. Again, CRP seems to be discriminating the risk among individuals even after being treated with the maximally tolerated statin and the PCSK9 inhibitors. So before I move on a bit more into the literature of the studies, I want to kind of go over and then summarize what I've discussed so far. So we've seen that the atherosclerosis is a chronic inflammatory disease triggered by the LDL accumulation, eventually leading into subintimal plaque formation, the growth, and then clinical events. C-reactive protein, CRP, seems to be a available and a reliable measure of the inflammation in atherosclerotic disease. And despite our recent successes in the preventive cardiology and in the lowering of severe risk factor management, some patients still seem to suffer from their residual inflammatory risk. So how do you move beyond the lipid levels? So I'm going to go over some of the kind of key trials in the past 10, 15 years that has kind of shaped to bring up the inflammation as potential target of therapeutics. So the first is the Jupiter trial. This is quite old now. It's a 2008 study. It was looking at it's as a double-blinded RCT in a multi-center trial, looking at the 17,000 people with normal LDL at the time, below 130, and then elevated CRP, meaning that they're adequately controlled on LDL, but they do have elevated levels of inflammation as measured by the CRP. Basically, this is primary prevention cohort without known CAD. We was trying to see if there's any therapeutic benefit of putting them on rosuvastatin 20 milligrams versus placebo, and they followed up to about 2 years. Basically, what they saw was that all the clinical trials, the trial endpoints were significantly associated with reduction in risk. These, again, this is a primary prevention course, so the event rates are quite low in general, overall, looking at all the graphs here. But if you look at it closely, there's about 45 or 50% risk reduction in all these primary endpoints, as well as these secondary endpoints as well. So what about the actual, how does that occur? So they also reported the changes in the CRP and the LDL. So entry levels LDL in the trial was about 108, which is higher than our more modern data on the PCSK9 inhibitor trials, but still it's not too bad. But we look at the change over time or the follow-up, obviously, as we expected, that the rosuvastatin arm does go down to about 50s, but there's a 50% of reduction in LDL level, and the placebo arm that stays around the same. More importantly, they're looking at the CRP level. So the baseline CRP level is 4.2, which is elevated, and going into the trial. But as we monitor the CRP level, the rosuvastatin arm seems to have decreased levels of CRP over time, all the way down to 1.8, as opposed to treatment arm. They were on about still ranging into the 3s. So that's about 37% lower CRP, whereas this 50% lower lowering of the LDL level in this trial. So is it LDL or CRP that's mediating this therapeutic benefit of the rosuvastatin? So they did a secondary analysis, and they reshuffled the patients based on two things. So they made this goal of the LDL at 1.8 millimoles per liter, which translates into about 70 milligrams per deciliter in clinical measurement, and then a high sensitivity CRP of 2. And then they were stratifying the patients into whether someone who achieved both goals versus one goals. So if you achieve either the LDL but not the CRP, or achieve the CRP goal but not the LDL, then you're the blue line. But if you achieve both goals, then you're the red line. So what this shows is that in the comparative placebo arm, if you achieve either LDL or the CRP level reduction, then you do get some benefits. It's pretty significant. But if you achieve both, then you have further risk reduction compared to having only one goal met. So basically, this analysis is telling that it's actually both the LDL and the CRP reduction that seems to be playing the therapeutic benefits of this trial. So the so-called dual target theory seems to be emerging from this analysis. So it's kind of summarizing. So this is telling us that even when the LDL is apparently well controlled, for when there's elevation of the CRP, i.e. with the residual inflammatory risk, the rosuvastatin seems to play a therapeutic benefit in reducing the adverse CV events. And this seems to be mediating through both the LDL and the CRP reduction. So moving beyond the statin, can we then now just specifically target the actual the pathway of the inflammation? And that's where the CANTOS trial comes in, targeting the IL-1 beta. This is very upstream of this pathway. This trial is now 10 years from that Jupiter trial in 2017. Canakinumab was a medication that was already out there. It's a high affinity human monoclonal antibody targeting IL-1 beta. It was actually approved for a very narrow spectrum of disease in a very isolated sense, targeting the treatment of the some inflammatory disease processes such as cryopyrin-associated period syndrome, Muckle-Wells syndrome. So indications were not broad, but it was still out there. But it's been shown to be able to reduce the CRP now 6 reduction up to 3 months with a long half-life. So thus this trial was begun. So they recruited about 10,000 people with a prior MI, so it's a secondary prevention, but also high CRP. So they do have, again, carry this residual inflammatory risk. And so it was such a new thing enough that they had to actually try different doses of the canakinumab. It was injection every 3 months, and they were following up to 3.7 years, and they were following up the outcome. This is baseline characteristics. There's a lot of numbers, but the main thing to take away from this is, I think, is that, again, this is being modern trial. A lot of them, 90%, 90+% of population was already being treated with the statins, and also the LDL level was already down to the 80s going into the trial. So they're relatively well-controlled patient. And again, due to the trial design, that people had elevation of the CRP at the baseline of the trial. What happened with the actual, and canakinumab actually did what it was supposed to do. It did drop the CRP level across the time span of the study. Placebo didn't really drop much, but then depending on the dose, there's a dose effect of the canakinumab. 50 milligrams of injection that dropped a little bit more than the placebo, and then 150 a little bit more, but then maybe 300 milligrams didn't make a much difference compared to 150. And it did not, unlike the Jupiter trial or Statin, did not reduce any of the lipid levels as it was supposed to. It was a monoclonal antibody against the IL-1 beta. When you look at the outcomes, looking at the 50 milligrams doesn't seem to be cutting much of difference here. There's no significant data. But looking at starting with the 150 milligrams, there's significant reduction in risk of the cardiovascular endpoint here, and as well as the 300 milligrams. And this is more broad key secondary endpoints. So the primary endpoints, the CV death, MI stroke was reduced significantly starting around the 150 milligrams. Again, when you include the unstable angina hospitalization, again, similar association was seen. But notably, the actual mortality and CV mortality or all-cause mortality didn't seem to be reduced significantly, even with the canakinumab. Another pattern that I mentioned is that to take away from this table is that the reduction in the event rate seems to be similar between the 150 and 130 milligrams, whereas the 50 milligrams seems to be between the placebo and the 150. So there is a cutoff effect between the 50 and 150 of the canakinumab dose. Because it's modulating the inflammatory pathway directly, so it's important to think about those side effects of this medication. Notable things that were found was there was a more instance of the leukopenia and thrombocytopenia, although they said there was no clinical significant bleeding risk, that actually there was increased incidence of the leukopenia and thrombocytopenia with the canakinumab. And also there was increased instance of the fatal infection with the higher doses of the canakinumab. Another thing that's interesting is that actually cancer seems to be more reduced in incidence, especially the fatal cancer with the canakinumab injection. And then as we had expected, the inflammatory arthritic conditions seem to be better controlled with the injection of canakinumab. Another kind of twist to looking at the data of the CANTOS trial is that dividing people into responders versus non-responders of the therapy. So there are two ways. One is a high sensitive CRP. As I said, this is the downstream gauge of the inflammation. So it turns out that not everyone does respond the same way. It's about 22% placebo and then 65% of the highest dose group were responding with a CRP level reduction down to 2 milligrams per deciliter, 2 milligrams liters, right? It's a typo. So using the 2 milligrams as a cutoff, and then we can divide up as a responder versus non-responder. You can see that when someone does reduce the CRP down below 2 milligrams at 3 months into the study, very early, their hazard ratio was about 75, so 25% reduction. Whereas if you don't respond by 3 months, then really you don't really get much benefit from this medication at all. And in fact, if you actually look at this responder group, and then they're looking at the cardiovascular mortality and mortality, which were null endpoints in the overall population, seem to be significantly reduced in the follow-up. Seems to be, if you're responding, that is not only the soft endpoints, but also you are benefiting from that from the mortality perspective. Same story with IL-6. IL-6 was divided into the median cutoff. So if you respond so that you drop the IL-6 down below the median by 3 months versus you're staying above the median, then the people who drop the IL-6 down below median seem to be benefiting quite significantly from this the medication than the non-responders. So one practical potential management path strategy is to give a trial injection and then maybe identifying the responders with assays such as CRP or probably CRP, then that will actually increase the cost effectiveness of this medication in the future. So just summarizing, this study was kind of a landmark trial looking at it. It was basically its first study to show anti-cytokine therapy with a significant reduction in the adverse events of cardiovascular disease. And there was dose dependence, and it was actually moderating through the IL-B, beta, IL-6, and CRP pathway. And we talked about potential concern that there's some side effect profiles that we should be careful about: leukopenia, thrombocytopenia, and the fatal infection, although there was no significant difference in mortality overall. So, but because the Canakinumab is such a kind of novel drug, and we're not really familiar with it, and it's expensive, so people started looking into, is there any other anti-inflammatory medication that we're already in the market and in clinical practice that we can utilize and redivert in their purpose to cardiovascular disease? And one of them is low-dose methotrexate. So that CIRT trial from 2019 is already widely used in rheumatology, as we know, for rheumatoid arthritis, psoriasis, and there's already observational data in the field showing that people who are on the methotrexate seem to be having lower rates of the cardiovascular events than people who are not. But however, the mechanism of action for low-dose methotrexate seems to be a little bit more broad spectrum than in the monoclonal antibody per se. For example, there's multiple postulated mechanisms that the low-dose methotrexate is working through. And it would increase adenosine release and stimulate the receptor, and then hindering the formation of foam cells, and also reduces the chemotaxis of the leukocytes by reducing the ICAM-VCAM. It may have some anti-atherosclerotic effects. So CIRT trial was done around the same time as CANTOS Trial, looking at the 47%, the 100 people with CAD, with prior MI and the multiple CAD, but then they also had to have diabetes and metabolic disease. But please note there was no inclusion criteria for the CRP here, as opposed to the CANTOS had a cutoff. So they randomized to the methotrexate versus placebo, and they followed them up. And the entry, that LDL was very low. Again, this is modern trials have already done really well with the LDL reduction down to 68 at the onset. And CRP, again, due to the trial design, was not elevated at the onset. And basically, this trial was negative. There's no difference in outcomes between the low-dose methotrexate and the placebo. But importantly, we should look why this didn't work. And I think one of the potential reasons may be that actually it didn't really change any of the biomarkers, didn't change any of the interleukins, CRP, and they really didn't change lipid levels, as it was already known. So basically negative trial, but no change in cytokine levels either. Again, maybe it's because we're not targeting the population specifically for those with elevated CRP, thus with the highest inflammatory risk, but again, it was a null trial. So then, we can go even more upstream to look for potential targets, and then looking at the maybe inflammasome itself at the onset of this pathway. And colchicine is similar in that, it's again, just like methotrexate, it's inexpensive, already in place of clinical medicine. It's oral medication, and it does inhibit the inflammasome indirectly by reducing the tubular polymerization, microtubule generation, by just kind of reducing the hindering the assembly of the protein complex, thus reducing the activity, the interleukin 1 beta, and also reduces the neutrophil platelet interaction and aggregation, thus reducing the inflammation overall. So colchicine has gotten a lot of press for the past 2 years because there's a lot of trials coming out. This is one of the more earlier ones, COLCOT Trial in 2019. This was looking at patients with a recent MI, less than 30 days. It's just interesting because if you think about MI, if it's in the just 30 days, we would assume that this is still within the period where the myocardium is still recovering, and then there's a process of wound healing. And inflammation may be still playing a role in helping or improving the actual repair. But either way, the study was done, and then looking at the MI less than 30 days, who has gone through needed PCI as planned, and already on the guideline-guided therapies for their post-MI care. And the randomization was 0.5 milligrams per day versus placebo, and looking at the usual the outcomes. This is the baseline trial data, looking at the characteristics. Again, main thing I want to point out is the medication profiles. Again, post-MI in the modern era, they're already on dual antiplatelet therapy, statins, and beta blockers. And this turned out to be a positive trial, meaning that there was, when you follow them up post-MI, there's about a 1.6% absolute risk reduction with about 23% of the relative risk reduction. Number needed to trade was about 62. But if you look at the actual components of the events that are driving the composite event endpoints, the composite endpoint it was significant. But if you look at the stroke and then the angina, it's not the death or the MI, it's actually the stroke, and more so by this urgent hospitalization for angina leading to the revascularization that's driving the overall relationship of the overall therapeutic benefit of the colchicine in post-MI. So what about the biomarkers? Did it actually do anything on the biomarkers? It was kind of suboptimal in that they were not able to measure the CRP level in all of the participants. They only measured into 200, which is really a subset of the study. Entering the trials, both arms had elevated CRP, which I think makes sense naturally thinking, because these are again in recent MI patients still healing likely from the acute event that they had just less than a month ago. But into 6 months, that both groups actually dropped not only the colchicine but the placebo. They dropped the CRP level down to 1.3 to 1.6. Really, but then the comparison of the degree of reduction between the colchicine arm and the placebo arm, there was no significant difference. So a small subset, no signal for significant reduction compared to the placebo group. It's really, I think it was shown, another thing that was shown is it was well tolerated. We worry about the GI side effects a lot, but in this study, there's some nausea and flatulence, but really there's no significant side effects other than this one thing that they noted, that there may be more instances of pneumonia in the colchicine arm. Again, but there was no change in the mortality or anything like that as a heart event. So this is the first trial to show efficacy of the colchicine in the coronary artery disease population. Small magnitude effects, but largely driven by revascularization, and the biomarker study was not optimal, and it was ended up being at best inconclusive to tell us anything about it. So what about the stable CAD population? So this goes back a little bit further down than COLCOT. There was a kind of small study in 2012 looking at 500 people, the stable CAD population. Same regimen, 0.5 milligrams per day, but there was open label. There was no placebo, but huge reduction in the risk, 67% hazard ratio, 0.33 ACS, cardiac arrest and ischemic stroke. But people were thinking, this is open label study, not placebo controlled and relatively small size, needs to be a validation. So it did. 2 months ago, this study, LoDoCo02, low-dose colchicine 2 trial came out, released in ESC and published in the New England Journal, repeating the study in a large cohort with a placebo control. So this is looking at 5,500 people with a chronic stable CAD that was defined by CAF, the coronary CTA or calcium score. They had to be clinically stable, meaning no clinical events for the past 6 months. It was randomized to the same regimen as the previous studies, but they also had a run-in period for a month on colchicine to make sure they can tolerate that. It turned out about 400 people actually had quit during that time due to the GI upset. And then they were following up to 28 months and then looking at these outcomes. Looking at the baseline characteristics again, same things. It's really typical of the CAD population in a modern trial population. The medication therapies, people are already on antiplatelet therapy. Some are on dual antiplatelet therapy, anticoagulation. A lot of them are already statin and even Zetia. So the prevalence of the use of the modern therapies are quite good. And it ended up being a very positive trial. So this is a CV death, MI, stroke, and revascularization. There was about 40%, 30% risk reduction in with the use of colchicine. When you take out the revascularization and just looking at the heart events, it still is significant. So that was very, very encouraging data. Looking at the different breakdowns of the endpoints for this composite endpoints, overall, most of the endpoints were pointing toward the benefit of colchicine. Mainly the ischemia-driven revascularization, MI, were significantly associated with the benefit of colchicine. But if you look at the actual death and CV death, actually, they did not turn out to be significantly associated with the big benefit in this group again. Adverse events in this trial, mainly there was a concern that non-cardiovascular death was a little bit higher in people with the colchicine arm, so that's something to note of. But when you actually look at the actual events and why they died, the interpretation of this is a little bit unclear and what to make of it. But that there was some trend toward increase in the non-cardiovascular death. So again, this is a first placebo-controlled study in stable CAD population. Although there's some tolerability issue and high risk of this non-CV death, and unfortunately, they were not able to test any of the lipid levels or CRP. But I think this is the meaningful data to show that colchicine seems to be really potentially could be playing a role in the therapeutics of the CAD population. So I want to kind of summarize the things that we've talked about. We have looked at this pathway and then looked at the various targets of the pathway as a therapeutic target. More trials are coming on the way. There's clear synergy, which is looking at the spironolactone and colchicine to factorial design. Looking at the acute MI population of the PCI, and there's also a study coming in the CONVINCE, which is looking at the colchicine used in the ischemic stroke. And there's some more novel targets, such as using mTOR inhibitors, looking at the ACS population in phase 2 trial. Some other potential targets that are still under investigation, not in clinical trials, are the actual direct inhibitors of the NLRP3 inflammasome inhibitors, as well as the interleukin-1 receptor and IL-6. There's some small data showing that the tocilizumab that are targeting IL-6 does seem to reduce the levels of CRP release and troponin in end-stage population, thus maybe smaller size of infarct. Unfortunately, some other targets such as phospholipase and P38 kinase did not turn out to be positive in a recent release of their data. So in summary statement, I just wanted to kind of go back to our concept of residual inflammatory risk. These are the pie charts of the patient population in the recent landmark trials, Approve It, Improve It, Aspire trials, and looking at who's achieved who's got inflammatory risk and who still had real cholesterol risk or both or neither. I want to point your attention to this blue pie fraction. which are the people who have achieved their LDL goal below 70, which is a target based on our current guidelines, but yet they still have elevated CRP. If you look at the other permutation of the two goals, these orange box, red-orange box, they are the people who have a low CRP level, but still suffer from the high cholesterol level. So the fact is that there's still a lot more people with the residual inflammatory risk compared to residual cholesterol risk. Yet we in the current practice and current therapeutic options, we are really still limited and more targeting on the cholesterol than the inflammation. So I think going forward, this is another figure from a recent review. We used to treat, we have been treating the cardiovascular disease and atherosclerotic disease with high intensity statin, mainly targeting the cholesterol pathway and maybe some inflammatory pathway. But depending on the individual patient, the phenotypes of their disease may be different. Some may have increased risk of from cholesterol. Some may increase risk from the inflammation. And there are the other components too. There's again another body of evidence coming out on the triglyceride, Lp(a), things like that. So I think that further characterizing and phenotyping someone's atherosclerotic disease beyond being just for secondary primary prevention, but focusing on what is actually driving their residual risk. For example, in this talk, residual inflammatory risk marked by the CRP level that's elevated. We can perhaps tailor the therapy to improve the outcomes of the patient. So in conclusion, I want to kind of conclude by some more treatments. So atherosclerosis seems to be an inflammatory disease triggered by the LDL accumulation and oxidation that leads to plaque formation growth. Despite success in our lipid-lowering therapies, many patients do still suffer from their residual inflammatory risk. Several recent studies have shown efficacy in targeting inflammation in the treatment of atherosclerotic disease, and in the future, identifying residual risk for individual patients and personalizing their therapies based on their phenotypes of this atherosclerotic disease will become even more and ever more important in guiding our therapies. So with that, I want to thank you for your attention. Also thank my mentor, Dr. Arshad Qayumi, preparing this talk, and I'm happy to answer any questions. Thank you.
John Hwan, can you hear me? This is Kunal Bhatt.
Yeah, I can hear you.
John, this was a great presentation and very comprehensive. Thank you again. I had two questions for you. So from this, if we are looking at the data and trying to clinically apply it, what are the therapies that are actually ready for real-time use, would you say? And then two, what do you think of the triglyceride lowering icosapent ethyl recently, which they think is also playing more of a role in that its risk reduction is more related to anti-inflammatory effects rather than the triglyceride lowering, because that's not very potent. So two questions for you. And again,
Sure.
Great talk. Thank you.
So I think, it's a great question, Dr. Bhatt. So I think the first step is to actually, so can we measure this? And I think we can. I think the data in the literature has been really strongly showing that, CRP is not a bad test. It's actually reliable, stable, and measurable assay to gauge, to quantify the degree of inflammation in someone's atherosclerotic disease. So this is measurable. So measuring it, I think, is the first step. Second, again, the colchicine is well-established medication in different fields of medicine. I think it's usable. I think there's a lot more data coming out. As I showed, there's some more data in acute MI population, PCI population. So I think there's some more data to be appreciated in the very near future. So we can potentially learn from that. So we could potentially wait, but I think it is still usable if we were to apply even today. But I would actually favor targeting the therapy after measuring the CRP level so that we can target appropriately. We don't want to just, I don't think that one size fits all therapy strategy is great anymore, because it seems to be that we have hit the point where we are dropped the LDL down to 30s and we are still seeing these high burdens of disease. So I think that the personalizing based on further measurements and or guidance risk prediction will be important. I actually haven't looked at the triglyceride data in depth yet, but I do appreciate that it may be that just like the Jupiter trial, rosuvastatin is not only the targeting the LDL, but actually it seems to be working through the anti-inflammatory characteristics of the medication. So I think it's totally feasible, but I think we gotta be able to kind of show in a systematic way that actually it is not the triglyceride, but the inflammation. But sorry, I haven't really looked into that, but I think that'll be interesting to see in terms of how that stands out in that part of the domain in the SDAD.
Great, thanks.
Thank you.
Hey, it's Stan Sherman. Can you hear me?
Yeah.
Great talk, number one. But number two, through the studies, we're talking about personalized medicine now. And was there any study that looked at the genetics in terms of the very young family history, in terms of the likelihood of elevation of CRP and their response to the anti-inflammatories?
Thank you for the question. I think there's a natural question that follows. I haven't found anyone myself, but I showed earlier a small bit of that, the Mendelian randomization study looking at the SNPs in the IL-6 location. And the people, or some people are genetically having polymorphism in the IL-6 position, so that they would have actually lower levels of CRP and thus lower levels of events during the lifetime. So I think is a small example that really tells us that it is totally possible that depending on the genetic predisposition, that someone may have already higher levels of CRP. And one other population that I'm not going to due to time constraint was that there's another a whole body of literature looking at the people with chronic inflammatory conditions such as lupus, rheumatoid arthritis, psoriasis, and they are, we already know from our clinical experience that they are at higher risk than the general population without it. So that actually, it does present as a subgroup of population at a higher risk of inflammation, and that does atherosclerotic disease. And again, there's whole set of trials looking at that population to examine the role of colchicine or the targeting specific targeting therapies of the interleukins and things like that. Yeah.
Thank you. Great talk.
Yep. Thanks.
The preceding program is copyrighted by Emory University.